Hello, everyone. I'm Karen Friedman Quinn, the Adult Programming Associate here at the library. And I'd like to welcome you tonight to the fifth and final session of this series. And tonight, the topic is skilled care. So I'd like to thank Oasis for putting on this series and for all of the really valuable information that they've given us over the past 5 months. So without further delay, I'd like to introduce you to Paul Dolan, who's a senior care advisor with Oasis, and he'll start the program.
Everybody, welcome to the fifth installment of the Sandwich Generation. We've covered a lot to this point, and tonight is some heavy stuff. We talk about skilled care tonight and what that means, both in and out of the home. Today we have MJ Auz, who's the Director of Operations for Amedysis Home Health. She brings with her 34 years experience as a nurse in the skilled areas of Stanford and Greenwich Hospital, WestMed Medical Group, a multi-specialty healthcare organization, and with many years in home health as well as in assisted living as a resident care director. Joining MJ is Ashley Rutigliano, Master of Social Work graduate from Fordham University with over 15 years of experience in skilled nursing facilities, where her responsibilities were clinical guidance, discharge planning, understanding the patient and the family as a whole. And most recently, she was Director of Social Work for 8 years at Greenwich Woods Healthcare Center in Greenwich. And for the past year, to our benefit, a senior advisor with Oasis Senior Advisors. So welcome to you both. Thank you for your time. Let's jump in and talk about, so we've thrown out skilled care. We assume that everybody knows what skilled care is, and I assume that every care I get is skilled. Uh, but we're going by the terminology. So let's talk about skilled care in general. Okay, whether it be in the home or in a facility, what are we talking about when it's skilled care? What are the types of treatments I'm getting? What are the types of professionals that might be engaged in that?
So I think professional is the term to think of when you're talking about skilled care. So you're talking about a registered nurse, a physical therapist, an occupational therapist. So those professionals providing the treatments in your home, that's what makes it skilled. Requiring an aide is not skilled care, or a homemaker to clean the house is not skilled care. So you're looking for that professional, that nurse, a registered nurse, a licensed practical nurse, physical therapist, occupational therapist. That's skilled care. That requires a doctor's order and specific treatment.
So what are some of those treatments? We talk about wound care. What are those treatments that a nurse is going to do that an aide cannot or shouldn't be doing?
Yeah, definitely. So skilled care, when we, like MJ said, we're talking wounds. So if you have a wound on your sacrum, that is specific skilled care. If you have a feeding tube, a J tube, a G tube, that is skilled care. If you need bolus feeding, that's skilled care. If you need diabetes management and it's more than just pricking your finger to check your sugars and insulin sliding scale, that is skilled care. It's not about a transfer from a chair to the bed or bed to the toilet. It is more than that. Like MJ said, you need a nurse. You have to have a care plan. It's very, very specific.
Now, and I think, MJ, you sort of touched on it. We use as the rule of thumb is that generally there's a prescription for it. It's a doctor order.
Yep, there is a doctor's order, but even with skilled care, you have to remember that it is intermittent services. So when Ashley mentioned wound care, yes, but it's not daily wound care. You know, 30 years ago when I started as a visiting nurse, we actually did twice a day treatments. Those were the days where you go in the home and do wound care twice a day or go give someone their insulin in the morning and the evening, and those days are gone. So when we're talking about wound care, we're talking about 3 times a week, but treatments are different. You know, there's a million different products out there. We guide physicians on what's appropriate based on the wound, and we can teach family members if that's what's necessary. But wound care, typically 2 to 3 times a week. Physical therapy, they're going in, they're working on an exercise program. Also, they're not coming every day. They're giving you a home exercise program. The expectation is you're practicing when they're not there. Hopefully you have somebody that comes to see you, even if it's a family member, a friend, they can help you with those exercises. Otherwise, you're not going to progress, you're not going to get better. Because home care, those services, intermittent, short term, rehab, completely different ballgame.
Very different, yep.
Okay, so and we'll touch on that because I think that also speaks to the insurance piece. But let's talk about, so how do I get there? The 1-800, I need skilled care.
You call 1-800 who's your doctor. The doctor decides, you know, you can tell them, sometimes that works, and then they'll make a referral. And then there's certain requirements that home care agency like mine, Amedysis, we all need certain documentation. That's the rule for Medicare, and all insurances follow the same path. So we do need orders from the doctor, but you also need to see the physician. You need to have had a recent appointment, or you're going to have a recent near future appointment. But those things we'll take care of. We'll guide the physician in what we need. Certain diagnosis, typically, you know, again, we guide them in what's appropriate and what is not to get the services, because we want to provide everything that's necessary, and we want the coverage to be there.
Right. Now, we were talking before we get started today about how does most introduction to skilled care get initiated? It's not generally the spouse or the patient themselves saying, I need skilled care. That's not the common path. Let's talk about the common paths that someone gets to skilled care.
Well, we're talking 2 different types of skills here, right? So we have the in-home health skill, and then we have the skilled nursing facility. That's what I'm
Right.
going to talk about. So how do we get into a skilled nursing home, okay? And I just want to make sure everybody is clear. Nursing homes, okay, if you think of, you know, Wilton Meadows, right? That's a nursing home, or Greenwich Woods, or the Villa in Stamford. Those are nursing homes. But a part of that, on that campus, other than the long-term care, is the short-term rehab, which makes it skilled, because you're going in as a skilled nursing patient. Okay, so how do you get in there? You get in there through a doctor, like MJ was saying. You get in there if you're going to a primary care visit and you're not looking so good, you may have to be directly admitted to the hospital, and then maybe directly admitted from the hospital to skilled nursing home. You can go from the community to a skilled nursing facility, but again, the primary doctor is key. There has to be a specific skill, reason why you need to be in a skilled nursing home. Mobility issues, nursing needs, infections. I mean, that's how you get in there. But generally, just to kind of answer your question, you're usually going through an ER, unfortunately. Unfortunately, a crisis happens. You go through the ER. The ER triages what's happening. Is it go home with home health, or is it go into skilled nursing? That's the gateway into the skilled nursing stay. If they feel like you can go home, then you might go home with Amedysis.
So there are a couple of things. So let's stay at that gateway for a second. because you don't just then leave the ER and this stuff is laid at the door, because you can't go straight from an ER to skilled nursing
Right.
and get it covered
Right.
by insurance, which is
Right.
part of this.
You
Right.
need to be admitted to the hospital,
That's right.
inpatient,
Mhm.
for 3 nights. It's a 3-night qualifying stay.
Yes.
And then whatever reason you're there for, you'll be, when the doctor is, starting to get ready for discharge, you'll be evaluated by physical therapy in the hospital. That's usually the golden rule, is the physical therapist in the hospital evaluating you to see how much can you do. Because you need to also qualify to go to rehab. And that physical therapy evaluation, that will really, write that script for the rehab in the insurance company. If you can walk 150 feet, 200 feet, you probably are going to go home. If you can only walk 50 feet, you probably should go to rehab and then go home. And when we talk about skilled nursing facility, the nursing home, remember we're talking about the short stay. You're only going there to get stronger, to get better, to go home. We're not talking about placement in a nursing home. It's just going there, getting stronger, feeling better, going back home.
And that's not an open-ended thing, right?
Nope.
I think what people don't understand sometimes is that there are stated goals when you're sent
Yep.
to the skilled nursing or referred to
Exactly.
skilled nursing,
Mhm.
not randomly. What does it look like? What is the hospital telling the skilled nursing facility?
It's all about the documentation. Like that physical therapist who goes to see you, and then they document in their note, she can walk 50 feet with a walker with somebody walking with her. That's really crystal clear. You're not safe to go home. And nowadays, everything is about safety because the hospital wants to make sure you have a safe discharge plan. That's their responsibility, right? So they want to make sure you're safe. So you go to rehab, that will most definitely be enough information for the rehab to accept you. And then once you're there, you'll be evaluated again by a physical therapist, and they'll develop a plan and a goal. They also consider, where were you before this event happened? Maybe you fell at home, but before the fall, what could you do at home? And they ask you. If you have family, they ask the family. They want information from your doctor. Hopefully the doctor knows what you were capable of before. And they develop a plan with you. What's your goals? What do you want to be able to get back to in order to get back home?
You must have, I mean, Ashley, I'm sure that over your period of time, you had plenty of people come to you from a hospital and their goals weren't exactly in line with what your team thought their goals
No.
could or should be. Can you walk me through? That must be a difficult conversation.
Always.
Like,
Yeah. So, yes, always. I shouldn't say always, but most of the time. And it was because of a few things. One being the insurance, right? So you're in the hospital, okay, just to backtrack, you're in the hospital, you can only walk 25, 50 feet, you go to a skilled nursing facility. Okay, what insurance do you have, right? So I have a Medicare A, or I have a managed Med A plan, like United Healthcare. And I can tell you that most of the time, nobody understood the difference between the two. I think I signed up for Medicare. I don't know, I'm not sure. So that was like the first conversation. And then they realized, okay, the skilled nursing team has a plan for you to only be here for 14 days. I can't get better in 14 days. How do I do that? Well, unfortunately, it's based on insurance. Insurance can dictate the length of your stay, or, that's if it's managed care, right? Like United Healthcare, Aetna, Blue Cross Blue Shield, or if you're Medicare and the team says, well, you can be here for 30 days. Oh, I can't be here for that long. So it's, it just depends on your insurance, it depends on your injury, or it depends on, the environment of your home, who was there helping you before? Did you have uncleanliness? There's so many factors to prevent you from going home, or it just took some time. It was different for everybody. Or family dynamics, or who was a power of attorney 2 years ago, and now we're switching it all of a sudden because, people have changed, or daughter moves away, son's here, who takes care of one more, the list can go on. But I would say those are the major things, like insurance and, psychosocial and environmental, which makes the stay either very short or it could be very long. Did I answer? I hope I answered your
Yeah, and
question.
I just want to say, I would assume sometimes people would say, get me better. Get me
Oh,
to
right.
what I was before I fell, or before I twisted my ankle, before this. And I think sometimes there's misperception or unrealistic expectations, and I just fashion that being a difficult conversation for you guys sometimes.
Yeah, definitely. I mean, somebody, for example, like they would come in with an IV antibiotic for 6 weeks, but they could walk, right? They could walk all around the facility. They have an IV antibiotic. How am I going to stay here? But it's 3 times a day, the IV. Okay, I'm just giving a case scenario because, I can walk. Why can't I go home? Well, the IV is a skilled level of care. And if you're living at home alone and you don't have a caregiver to do that, which typically you really can't do that, or you don't even have a home health agency that can do it 3 times a day, you're kind of stuck there. Which is, it's not very exciting to stay in a skilled nursing home, but it's very needed because you need to be around a nurse, you need to be around a doctor, they're taking blood work, it's,
MJ, just for you and getting home health, if somebody's coming from a hospital or coming from skilled nursing, the same thing is like that it's not a negotiation, but that meeting of expectations and reality, as families come to you and you come up with the care plan. Can you talk about that
Yep.
experience a bit?
Most of the time, people think that we're going to stay involved forever. And that's not the case. Everything is insurance driven. That's the world that we live in, right? So my clinicians, my physical therapists, my nurses, they document how's the progress. And if you're showing progression, let's say the wound is getting better, it's getting smaller, that's progression for a wound. Physical therapy. If you're progressing and the physical therapist can work with you and you're not short of breath and you don't have to sit down, you can do more than 5 minutes, that's progression. But if you are the patient who, you may have a terrible respiratory condition that you're on oxygen and you get very short of breath, you can't do a lot of physical therapy. You're likely not going to get any better physically. Those are the conversations that are very difficult because nobody wants to hear that. They just want the physical therapist to keep coming. And that's not restorative treatment. That's what we call maintenance. That's maintenance, and that's what insurance does not pay for. That's what your home exercise programs are for, that the therapist is giving you. Some people might have a terrible wound, and it's not going to heal. But that's a very terrible wound, and it isn't going to heal, and they are out there. It does happen. Usually they are what you might call a bed sore. We call them pressure ulcers. And sometimes they don't get any better because the patient doesn't follow our recommendations, like don't sit all day long, or your mom needs to be turned and positioned every 2 hours in bed. But if you don't follow our recommendations and the wound is not healing, then it's considered a non-healing wound. Insurance will no longer pay for that either. So we're teaching the caregiver, because if you have that kind of wound, you have a caregiver with you. then we have to teach someone to do that wound care because it's going to be like that probably forever. Those conversations are horrible. No one ever takes that in a good way. There's no easy delivery of that. And also, nurses and physical therapists don't want to deliver those messages either because they want to make everybody better. That's why they're doing this job. But yeah, difficult conversation.
So when we hit that point where our expectations are beyond what I'm going to get, I want to just explore the type of things that how I should react. And one I would say is, what kind of advocacy can I be as we get down there? What are the hints, tips, or tricks for advocating to extend or augment? And the other is, when I've exhausted that, what should I be doing? Because that wound didn't disappear just because I can't get care anymore. So those are two different, but when I've hit that sort of inflection point and I'm nearing it, talk to me about the advocacy I can and should be doing, whether I'm coming out of the building or going into coming out of care from the home health.
Well, in home care, if my staff are doing their job the right way, they should be preparing people for discharge. It shouldn't be, today I'm telling you I'm not coming back next week. That should not happen. If you've ever been in the hospital and you've been given a notice of non-coverage where they're preparing you for discharge from the hospital and they have you sign a piece of paper and you can disagree with that and you can call the 1-800 number and appeal your discharge, the same thing serves in home care as well. So my staff would give you notice, we plan on discharging, and this is why. They serve you with the paper, you call the 800 number and you say, I want to appeal the discharge. That company then notifies me and wants all the medical records to be reviewed. And then they're either going to agree with me or they're going to agree with you. And if they agree with you, then we keep going for a certain number of times or weeks, whatever we agree upon, and then we see how it goes. Most of the time, if you're at that point in your home, then perhaps you shouldn't be at home. It might be at that point that it's not a safe situation, and maybe an assisted living might be the right decision, maybe a nursing home might be the right decision. We call that a higher level of care. And what we would recommend at that point would be somebody like Paul, that, with your consent, if you wanted help to find your resources like that, then we will call somebody like Paul and put them on it. You need a higher level of care. Assisted living would be, and lots of times that would be the right decision to make.
And Ash, coming out of a skilled nursing facility, of a rehab stint, is that a similar experience, or how does it look when?
Yeah, it is very similar. When you're coming into skilled nursing, the social worker is the one that you would want to befriend because they really are, sort of driving the care plan. They facilitate a lot of what you do there. They're not the doctor, but, in terms of understanding what you're there for, okay? Because you might, you may have heard it from the doctor in the hospital, but you need clarification. So you're really initially getting a 72-hour introduction, and you're going over discharge from day one. Okay, so just like you said, you're talking about the plan from the second you get in that bed, which is always kind of like, oh, that's I just got here. Can you? But there's a reason for that, because you want to make sure it's very clear that it is a short-term stay, that it's always subject to change based on insurance, based on your needs, based on your wishes personally. It really just, it depends. So yeah, we talk discharge from day one. We talk about Medicare, whatever the coverage is, why you're there, who's going to be taking care of you, the purpose of the stay, for how long, and be prepared. There will be a discharge plan as we go through every day. We're going to talk about it. You might, this is what I would say to people. We're going to have a care plan halfway through the stay to discuss with the interdisciplinary team what's really going on, what you're going to need to put in place. Is it going to be some home health? Is it going to be DME? Is it medical equipment? Is it going to be that you're going to need a 24-hour caregiver? Or do you need a nurse? Or do you need assisted living? In that sense, we would refer to Oasis, right? So, or do you need to stay in memory care? Do you need a secure unit? Whatever it is. Yeah, these conversations were hard, but families would appreciate how transparent we were from day one, because then they were prepared. So if you ever do have to go into a skilled nursing situation, and I hope you don't, please do your advocacy, go to the social worker, be present to the team, let them know you care, or that you don't care, whatever. It really is important. These things are real, okay? You wanna make sure you express yourself and you're there every step of the way so that you clearly understand what the next steps will be.
Yeah, and I think there's a booklet in the back about discharge, and I think it applies to hospital discharge, skilled nursing discharge, and home health discharge. Is discharge planning starts upon admission.
Right away.
First day, you don't know enough to discharge,
Right.
but your focus has to be on discharge from that moment, because you're also not going to get the hand holding. You were talking about you're very gracious. The social worker's not talking to you every day.
No, they're not. No, not all social workers will talk to you every day. They are very busy. Doesn't mean that they're not good at what they do, but you do have, like I said, you do have to be a good advocate. You want to make sure you check in. It doesn't have to be every day, but throughout the weeks. Ask questions. Is there going to be a meeting? Should I speak to the doctor? When is the doctor coming? If they have a wound, is there a wound care doctor? Right? Because people think there's only one doctor. No, there's a specific wound care doctor. There is a podiatrist for feet. There is, all these different players that you don't know unless you ask. So really, again, befriend the director of social work, discharge planner, whoever it is, and ask good questions. It's very important.
So are cookies better than coffee?
Well, for me, it was coffee, but yeah. But yeah, it's a really hard place to be. It's not very fun, but you just have to really embrace it and don't do it alone. You don't want to go through the process of this alone. So if you have family or friends that you can include in keeping track, make sure you take notes. Because it's hard to gather all this information. The next day you go in, you're like, I don't know what's going on with my mom or my dad or my sister or my brother. You have to make sure you're taking good notes and that you are understanding clearly what the purpose of the stay is. I can't stress that enough. You get lost in that process, okay? And then you think that the team is not doing their job, but they are. Make sure to take notes.
Okay. Now you raised an interesting point with that there's a wound care doctor, and we see that all the time. Somebody went in for a broken hip, and so that's what we're focused on. Why is mom in the hospital? Well, she broke her hip, and she's in rehab now for the broken hip. Why is she not coming out? Because she's got a wound.
Yeah.
It's not the hip's fine. Hip's fine now, and I'm sure MJ, you were talking about before that. Those are the type of things that can go on. And how do you moderate it? Because you're not in charge of making the wound better. You're in charge of delivering the care that somebody's prescribing for that. And it may not be my primary care physician.
Yep. There's a lot of players. There's a lot of doctors involved. We usually have one doctor that's the go-to, that's signing our orders. But some patients do go to a wound care center, but they have to be physically able to get there. And if you're home and you're not that mobile, you may not have finances that can cover expensive transportation. Primary care doctors, they will give us orders. Most every home care agency has a wound care specialist of their own because the industry kind of demands it, because you have patients that are homebound and truly cannot get to the doctor to have that wound looked at by someone who knows what they're doing. So my company does have wound care specialists. We use virtual visits. The patient or family signs a consent. We use Teams on our tablets. We use photos. Everything is live. And then those people, our specialists, they make recommendations. And then we go to the primary care doctor. That's not their specialty. And we say, you know, Dr. Joe, we had the wound evaluated by our specialist. This is what they think this product, this treatment might work. If you're in agreement, we can write the orders and you can sign and we can give this a go, see if we can get this wound to heal.
Great.
And that's very, very successful.
Okay, I want to make a transition to the people who are allowed to do certain things in a second, but I want to put a button or pin in our stays in skilled nursing. Actually, I want to get into home health on that. 100 days. Can we just talk about the 100 days and the reality of what that is? The amount of time said, well, when I asked, well, when's your mom being discharged? Said, well, it'll be 100 days. She gets 100 days.
Yes, so please understand your insurance, what it is. Okay, that's the first thing, right? If you have Medicare, Part A and B, call up and find out what does that mean, okay? And if you have United Healthcare, which is a managed care plan, managed Med A, understand what that means. Both give you 100 days. Yes, they give you 100 days. However, there has to be a skill to use the 100 days. Okay, so for example, you go into a subacute rehab, skilled nursing, you're admitted, have never used a Med A day in your life, right? You go in, you use, 25 days. But the family says, well, I have 100 days. How come you're kicking me out on day 25? Well, because like I said, we talked about discharge from day one. We went over the care plan, the purpose of the stay, and the goal for your total knee replacement is to be out on day 25 because you've met A, B, C, D, E, F. And now you're good. You're good to go home on day 25. Well, no, I have 100 days. Well, no, because the care team, the interdisciplinary team, physical, occupational, nursing, doctor, they all feel that we can't justify any more to Medicare or to managed care, whatever, and you're okay to go home. You're okay to go home. We can't justify it. We can't, you've met your goals, you've plateaued is another word they use in these types of settings. And that's a good thing. That's not a bad thing. If you felt like you wanted to sort of, appeal that process, you will get that opportunity and you will get that right. Like you were talking about before, there's a notice of Medicare non-coverage. They call it a NOMNIC, and you get that opportunity. They should, not every place, it depends on where you are, but typically they like to give those notices 48 hours before you're discharged. They should give it maybe 7 days before, so you have time to plan. But they technically have within 48 hours. And then you get the notice, and you like MJ was saying, you can call the number and you can appeal. And if you don't win, it's okay. You've met your goals. That's why from day one you want to be prepared. You might get cut on day 25. That's okay. Have a plan. But yeah, to answer your question, you have 100 days, but you need to have a skilled nursing need or a skilled, a skilled nursing need. Nursing, PT, OT, speech. That's a medical issue. Those are skilled needs.
Now,
And
and to get to the point where I'm going through the same experience at home, I want to start at the beginning when I'm at home. You mentioned I might have physical therapy coming in. I might have occupational therapy going in with their stated goals. I've got my broken hip or whatever's going, and there is a regimen for what we're doing. But if and maybe even I have a wound, and you've got a wound specialist coming in or a nurse coming in to redress a wound 3 days a week. But those people are only there for those periods of time.
Yep.
I'm not going to Target on my own and doing I'm still hurting. I just got out of the hospital or rehab. What are the other pieces that I'm putting around, or what are the scenarios you see that we have to add, and what's covered and what's not?
So usually, I want to say most of our referrals come from the hospital, and the case managers, the discharge planners in the hospital do a really good job of assessing you and what your functional level is, what kind of help do you have at home. Not everybody has somebody in the home with them, but that discharge planner makes sure that, you know, okay, she has a daughter and the daughter comes once a week and puts frozen meals in the freezer, or they are getting, Meals on Wheels is going to deliver. Again, that's part of your safe discharge from the hospital. Um, you need to be able to, what we say, mobilize yourself when you get home. So, okay, you can't walk 100 feet, but I need to make sure you can actually get out of your bed by yourself and get to the toilet. You can get out of your recliner and get to the toilet if you're living alone. Otherwise, you should not be alone and you need a caregiver with you. And I want to say 9 times out of 10, the discharge planner in the hospital does a really good job of identifying those issues. If my staff gets in your home and that's not the case, then we are going to say you're not safe to be by yourself and you need some help. And then there's resources that we can give you. Sometimes it's really not good and we're going to send you back to the hospital. Because sometimes they might have missed something. Maybe somebody wasn't truthful. I mean, we all rely on information and we're hoping the best that we're being told the true story. But sometimes that's not the case. And we have to send someone back to the hospital and maybe they need to go to rehab. Maybe going home was not the right decision at that time. So everything is good. We're going to come back. The nurse is going to come 3 times a week. And then maybe you're also getting physical therapy. So I tell my staff to not everybody come on the same day. First of all, that's exhausting. But second of all, we try to spread our visits out so that if my nurse is going Monday and everything is great, and then physical therapy is going to go on Tuesday, they're going to do their thing with the exercise program, but they're also capable of doing a blood pressure. They're also more than capable of listening to somebody's lungs. They're capable of checking the medicines. Are you taking your meds? Show me. So that's the preference. So as many different professionals that are seeing you, I try to educate my staff to spread those visits out so that we have eyes on you as many days as we can, right? Having 2 or 3 different people going in and seeing you on Monday and then nobody comes back for a week, chances are you're back in the hospital by Friday. And I'm not happy when that happens.
Now, for those times, if at least in the beginning, say I can't get from my bed to the toilet I just need somebody under my elbow.
Then
A
you
little
need to
bit.
have a caregiver.
And so how does that happen? How is that initiated? Can it be initiated from the hospital? Can it be initiated by you guys? Can it be covered by Medicare? If it is,
Yep.
what
So
are the limits?
those things should be initiated by the hospital, and most of the time they are. If it isn't, and that's what we find when we get in the home, we're going to say you need somebody with you. If you have family, if your daughter or your son is your power of attorney, or maybe they don't have any legal anything, but they're your person, we're going to call them and say, Mom is not safe to be here by herself. She needs somebody. What can we do? And if they say, well, I'm not going to do anything, we can call, don't everybody fall off your chair, we can call Adult Protective Services. That is not a punitive action. That agency is state appointed and they are there to make sure, again, that people are safe in their home. And they can help see, is there resources out there that can help put somebody in the home to help you. Somebody like that needs to be with you for safety purposes is not something covered by insurance or Medicare. That's a private pay situation. Sometimes Medicaid will pay for things like that, but your Medicare, your Anthem, your United, those things are not covered. Those instances are very rare, honestly, because I think the hospitals do a really good job of saying, you know, these are the reasons why you should not go home. You need to go to rehab first to get stronger before you can go home. Yeah.
Can you speak a little bit? So when I made that transition then, and I've gotten home care,
Yep.
not the
Yep.
professional. I mean, they're professionals, but what, what can they do by regulation? I know physically anybody can help me get out of bed,
Yeah.
but this aid won't, or I need some help reminding me, is it the blue one at night or the white one at night, the pill that I'm taking? And what is sort of, people, I think, sometimes misunderstand the capability of when people are hamstrung by what the regulations are as opposed to.
So if you hire an aide through an agency, which we recommend because then you know, hopefully you're getting somebody that um, knows what they're doing and is going to follow the rules, and they have a boss that's going to make sure they show up for work. So, you know, hiring through a licensed agency is a good idea.
And an aide is a certified nursing assistant.
That's an aide, right? And they can cue you. So no, they can't give you your medicine out of the bottle. But if you are aware of your medicine, my nurse would know that. Okay, she knows all of her medicines. She just can't take the tops off the bottles because she has arthritis. Okay, there's other ways around that too. There's pharmacies that my nurse can work with your doctor that packages medicines beautifully that you can open, no problem. But an aide can assist you. You're just going to say, it's time for me to take my Lipitor. It's 7 o'clock. Can you pass me the bottle? And can you just unscrew the top for me? That's perfectly fine. An aide cannot do wound care. She can help you get to the bathroom. She can walk with you. She can do the exercise program with you. They can do all of that. If you hire somebody through the church or a community center and they're not through a licensed agency, it's your cousin's family's nephew, sister's brother, they can do whatever you want because you're hiring them privately. If you want to teach them how to do something, that's on you, right? They're not a licensed anybody. They're just a friend of a friend. And there's nothing wrong with that. That's a personal family decision if that's what you want to do. There's lovely people out there, but you know, that's on you. If you hire through an agency and they are an aide, then they are limited at what they can do. It's, again, it's queuing, it's assisting you, but you have your faculties, you know what your medicines are, maybe you just can't reach them.
And can I just piggyback? This is one of my, this took up 80% of my day when I did discharge planning. Because families, you know, when we're talking, okay, in the meeting, you need home health. Okay, that's one part of it. But then you also need an aide in addition to the home health plan. Home health is the covered medical model. And then if, you know, that's intermittent care throughout the week. So, okay, think about it. You have 24 hours in a day. The home health agency is only going to give you maybe 2 hours a day, maybe 3 visits a week, something like that. I'm just, right? It's very, very limited. So to understand that part was huge for me to deliver to families because they say, well, home health, I mean, it's covered under insurance. Well, it's not. It is, but it's not covered 24 hours a day. So you really have to listen to the care team and fill in the gaps. So if you do need additional from home health, like a private aide, that's a separate situation. That's still an aide, a certified nursing assistant that can physically do the care, can't do the pills like you were, you know, they can't, you know, here's your Lexapro, here's your, they can hand you the bottle and, okay, so it's really important to understand that, you know, home health, home care, and what you're going to get throughout the day. Because that took up a lot of time to understand. And then, because people think, oh, I'm going to go home with the care and it's gonna be fine. But then there's pockets throughout the day, and that's when we can have these crises, right? So, you know, it's really understanding what you're getting from each agency and what you're getting from under your insurance plan and understanding that.
Now, MJ, I was just thinking about this, especially with your background, both long-term and when you were in assisted living. There's a phrase that we use a lot that comes into play that I don't think most people are aware of, which is chronic and stable. And chronic and stable mean they mean the same thing, but they trigger different things in home health versus, say, assisted living. In one place, it's the green flag, and one place, it's the red flag.
Yep.
Can you talk about that phrase?
So in assisted living, and everything's about regulations and rules, and it would be great if they all work together, and they don't. In assisted living, the resident has to be chronic and stable. And the reason is that in the state of Connecticut, assisted livings cannot provide what they call skilled care. You can have your medications given to you by the nurse in the assisted living. That's the extent of anything medical in assisted living. Even if you are in memory care in assisted living, the most that the nurse can do is medication. If the doctor says you need wound care, those nurses are not allowed. Are they capable? Probably, but they're not allowed because that's considered skilled care. That's when the doctor would refer to a home care agency to have a nurse go in. We can go into an assisted living, not a nursing home, because nursing homes don't need my staff, they have their own. But in an assisted living, because those nurses are not allowed to do skilled care, my visiting nurse can come in and do wound care. Now, if something happens, because that resident in assisted living must be chronic and stable, if anything happens, the nurse will call 911 and send you to the hospital. And that's not what I want, because, by the way, that looks very bad on my statistics that my patient went to the hospital. And that's where our models do not align. You know, a fall is very straightforward because you can't tell if someone is really hurt. So you get sent to the emergency room to be evaluated. Did you break anything? No, you didn't. So they send you back home. But let's say maybe you have a history of congestive heart failure. If my nurse could be called, you know, what we would do if you weren't in an assisted living and you were living in your home down the street, if you noticed that your feet were swollen and you were a little more short of breath, we instruct you to call us because we are available. That's what we're doing. And we want to get out there to see you. Let's say the nursing plan was we're coming twice a week to see you, and you have congestive heart failure. You were just in the hospital. The doctor adjusted all your medicines for you. So we're following you twice a week at home. But we're teaching you. I'm coming back Thursday, but in the meantime, it's Monday. If you get up tomorrow and your feet are swollen, and we also teach you to weigh yourself, and you get up tomorrow and you weigh yourself and you've gained 2 pounds, that's not from the chocolate cake you ate. That's fluid. That has to do with your heart. You need to call the office. My nurse is going to come out the same day, and she's going to call the doctor and say, Mary gained 3 pounds overnight. Her feet are swollen. What would you like to do? And most likely he's going to say, I want to increase her Lasix. And that's what we're going to do. And we're going to try to keep you out of the hospital. But when you're in assisted living, what happens is the nurse in the assisted living goes and sees you and you're short of breath and your feet are swollen and they send you to the emergency room. And then, or they might not do anything because they don't do skilled care and they might not have caught that and neither did you, and you wait and now it's 48 hours later. Now you really need to go to the ER and then you're admitted again and you have a hospital stay. So we do a lot of educating. My nurses do a lot of educating, and I think one of our biggest challenges is that chronic and stable situation
Because it ends with,
With-
that means you stop in the home.
with the assisted livings, and my nurses don't understand either. And I have a background and I'm trying to educate them. It's not because those nurses are dumb. It's not because they don't want to do their job. Legally, they're not allowed to do that. There's also, a wound treatment that we used to do forever that is no longer a skill under Medicare. And sure enough, every doctor in assisted living in the state of Connecticut always orders this wound care for a skin care. And it's not a skill anymore. So now we're trying to educate all those docs in the assisted living. Xeroform gauze is not a skill anymore. So we have to do something else or we can't do it. But to the assisted living, it is a skill. Those nurses are not allowed to do it. So it's so complicated.
It is.
But it's great to have, I'm fortunate that I've worked in different arenas and I can help people put it all together.
So I want to get to something real simple that we can button up with and open up to any questions we have. You talked about looking at the environment at home and how to prepare it, because it's not just about having the people. I may have to make some modifications. I may need things that I didn't need before. And Ashley, you mentioned DME or durable medical equipment. Can you just talk a little bit about the most common pieces of equipment that you're making orders for, and the idea that you have to make an order because we can get Medicare to pay for something?
Yeah.
So give me a typical discharge where it's some of the pieces of DME that.
Yeah. Well, usually it's a rolling walker. I mean, usually you're not leaving a skilled nursing setting walking out. Like in my many years of skilled nursing, I had very few patients walk out without an assistive device. And that's the truth. That's okay though. Doesn't mean you've done a bad job. You just need a walker or a cane, very few canes, or you might need, in some cases, you might need a wheelchair with leg rest to elevate your feet, to prevent any swelling. Maybe you need a hospital bed. Maybe you need a commode for over your toilet seat so that it raises, it's easy to get on and off. Maybe you need a grab bar. Maybe you need a shower chair. These things are not bad, okay? Folks would be like, I don't have space for this. Well, I can tell you right now, if you have a small New York City apartment, it will fit in those places. It will fit in your home, in your, whatever, it will fit. Trust me, because they adjust. These things are covered under Medicare. They are not all covered under Medicare, but the big ones like hospital bed, wheelchairs, those are usually covered. Mattresses, when you need a mattress to prevent sores, that's when we're getting into like, maybe there's, some private pay costs, but honestly, these devices are worth paying for. And if you need it, if you can't afford it, there are other avenues you could take to rent and things like that. But yeah, I mean, durable medical equipment is very, very helpful to help you get around your home. Don't think it's not ugly, it's prevention, and they're great tools.
Okay. Well, and thank you both very much.
Yeah.
If anybody's got any questions.
Depends, because an aide is licensed as well, and they're not. No. An aide is an aide is an aide. I mean, everyone has, during their working life, I mean, you could be an aide and you've only worked with children, right? But if you're in home health, then you're accustomed to working with the adult population. Yep. 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 Just ask them. Yeah, just ask. And also, every state is different, by the way. Regulations are different in every state. And Connecticut has one of the most stringent regulations. Our state regulations for Connecticut are very strict, both for home health, for assisted living as well. Yep, you're welcome.
And when you're going through an agency for a certified nursing aide, you can ask, because I think this came up in another one of our sessions, where what can the aide do, right? Can they transfer from the chair to the bed, one person? Do I need two aides? You know, you really need to be you yourself as the family member or whoever, right, need to educate yourself, ask questions. The agency can tell you what the certified nursing aide can do, because maybe the aide might say, I can't do that. Well, go back to the source, go back to the agency and ask them, what can the aide do for my 98-year-old mother who can't do a transfer on their own? Just an example. So don't ever feel like you can't ask questions to the agency representative. Oh, I see.
It varies state, it varies state to state. It's not just south. I mean, you can go south. There are plenty of places to think Connecticut's the wild, wild west. Your neighbors to the south think Connecticut's
Did you
the
have
wild,
a
wild west.
question? No.
No, no.
So
But let's
people,
touch on that a
Yeah.
little bit.
yeah.
So
That's
there are
important.
two things. The supplement is about when you get to the gap. Like if you're getting 80%, the secondary insurance is going to cover that for when you're there. So you're 100% under Medicare for the first 20 days. Day 21 to 100, it's 80%. So what happens to the 20% bill if you don't have a secondary? You're on the hook for it. That's what you want. But it also brings up the question, and it's different, like managed Medicare. And Ashley touched on it a bit, but I think people don't understand this, and this is why we tell people make sure you check, retool your health insurance every year. Open enrollment is in the fall. They make a big deal of it, and go and get it evaluated because your life situation changes. It's like your life insurance when you're 40 and 2 young kids is different than when you're 70 and the kids are gone. So it's the same with that. And you're faced with, if I have managed Medicare and I'm in a skilled nursing or a hospital, I can switch.
You can, but you can't do it during the active stay, because it becomes a billing issue. So, you're there under United Healthcare for a skilled stay. You're like, well, no, I really want to switch because I really want mom to stay for like another 20 days. Well, don't do it during the middle of your active stay. You really have to wait. Actually, you really need to approach the finance office in the skilled nursing facility. But you have rights. You can do that. It's just you might have to pay a little bit, or it could be retroactive until you get Medicare. That's complicated. I mean, I know enough about it. I could walk you through it, but yeah, you really have to go to the finance office if you're in a skilled nursing facility to say, hey, I want to switch over to Med A. Can I do that? Guide me through that. Really go to the finance advisor or finance officer at the skilled nursing facility. And if you have United Healthcare or Aetna or Blue Cross Blue Shield, like the managed care plan, it's usually because folks sign up for that because you're getting more in the community. Like people sign up for that because when you go to a primary doctor, you go to a specialist, you have very few co-payments. That's really why it's ideal.
Or it's about medication.
Yeah, or it's about
a lot of
exactly.
times the advertisements
Yeah.
are, You know, you'll get your meds for, you know, no copay. And if you
Desirable.
take 24 pills a day, then that might be the better option for you.
Mhm.
If you have straight Medicare, and that means you have not enrolled with United or Anthem or Blue Cross, then the guidelines are very straightforward. If you are enrolled with anything else, United, Anthem, Aetna, whatever it is, it's managed Medicare, that's what it's called, because they are managing your Medicare. So then the me and the Ashley, we have to follow what those insurance companies are saying. Medicare has
managed.
very straightforward guidelines. For visiting nurses and physical therapy and everything, for instance, Medicare pays 100%.
Mhm.
As long as you meet the requirements. You're homebound, and we have doctor's orders, and we have a skill, and you're showing progression, Medicare pays 100%. There are no supplementals in home care. That doesn't come into play.
Like AARP.
Right, that doesn't come into play in home care. If you have a managed policy, let's say it's United, it could be that they're following Medicare guidelines, it could be, or they may require authorization. So you still need to be homebound, we still need doctor's orders, there still needs to be a skill, you still need to show progression, but they will say, okay, you can have 5 physical therapy visits between May 1st and May 15th. And then at that point, send us all your notes, show us the progression of the patient, and we'll see if we'll give you more.
Yes, sir.
Those are usually pretty good from my experience, but I'm no specialist in that.
Well, it's gonna, right, but each, on that supplement, it's gonna be different, just like when you buy any other bit of insurance. And that's why I would say, an open enrollment, always check it out. And the most important acronym in the state of Connecticut for that piece is choices, the word choices. The choices are people who are trained to give advice and walk you through which might be best for you. So as MJ's saying, if you have a lot of pills to consider, let's do this. If it looks like you're at a point in time, you have congested heart failure, your feet swell a lot, and you've had a couple visits to the hospital, maybe we should be thinking about this, because that copay on the meds is not going to be as bad as the copay in the skilled nursing and you're more destined to go back there.
Yeah.
But for some people, that's significant.
We can't.
Yeah, we can't. No,
No.
we can't.
You have to make your own. Unfortunately, that's something, we've
All
got a
about
marketplace, and
education.
we go shopping, and you like those oranges, I like these
No.
oranges.
You told me
We
to
have
go
a
to
hint,
Aldi,
but-
the steak was so good there. No, it wasn't.
The perfect analogy.
Right?
Yeah.
Anybody else?
In the home care arena, when you have a patient with dementia or any kind of cognitive impairment, skilled nursing services, so the registered nurse seeing that patient, If it's wound care, then, that's not an issue. But if it's something that requires education about medicine, hopefully there's a caregiver or that patient's not safe to be home alone. And we would call Adult Protective Services. There is a caregiver involved and the doctor wants physical therapy. Sometimes they can do that for a little while and maybe provide education to the caregiver on home exercise, but that patient's not going to retain that education. So the caregiver is taught, then they do that home exercise program when the physical therapist is not coming. Or maybe they need teaching on wheelchair transfers or bed mobility, something like that. And if they're at home and there's no caregiver and the family, can't do that, maybe they're not local, whatever the reason would be, assisted living is a great option in one of their memory care settings, or skilled
Yeah.
nursing facility.
Yeah. On my way here, I was talking to a family member, called me and went over this exactly, that they are the caretaker for their mother, and she has 2 younger children, and she was like, I don't know what to do anymore because I work, my kids, they love their grandmother, but my mom let the cats out and then went after them and then didn't know how to get back inside and then has been combative. I mean, these are things that you want to listen to, right? Somebody's combative physically, or they're, verbally, or they're kind of getting lost within the home or outside of the home, or they forget to turn the stove off, or they said they took their meds, or they said they took a shower and they didn't. I mean, these are really important memory care points to kind of take a look at, right? So she said, what do I do? Well, I mean, I did provide her a lot of good options. It all depends on the financials. It depends on the care needs of the patient. So breaking that information down really helped her. If it's not assisted living, in the memory care within assisted living, because you can't afford it, then you may need a skilled nursing home, what I was talking about, that has a memory care unit within the nursing home, because not all of them have memory care, meaning it has to be locked, secure, with memory caregivers. I mean, these caregivers are trained in dementia. There is a difference in some of the certified nursing assistants. They go this extra mile to get a certification for dementia training. Most of them have it, but it's very specific, because the way you approach somebody with dementia is very different than, maybe not that much different, but a little different than you would approach somebody that doesn't have a memory care issue, because they may not be so hesitant or paranoid, whatever symptom they're having, right? So those are key points for memory care folks, right? You really want to look at internally and externally what's going on, and not just all about the medical things. It could be the behaviors, it could be the, all these signs leading up to the need for nursing home or assisted living or home care.
Anybody else?
Yep.
Good point.
Yeah.
For any of the other questions, oh, sorry.
So for long-term care insurance, that is for personal care. So that is for care that an aide would provide. So not skilled home care. That would be for an aide to provide. That's how we say tap into your long-term care policy. Yes,
It could
and
too. Yeah.
in assisted living, you would need aid services.
Mm.
So when you go into assisted living, you would be assessed by one of their nurses, usually the director, and they would determine with you what your needs were. Really simple. Let's just say you need an aide to help you every other day with the shower for safety. They don't need to get in the shower with you. They just need to help you get in, turn the water on, and wait for you, help you get out so you don't fall. Most of the time, that's going to qualify for your long-term care insurance. And then they usually have, they'll tell you what their daily pay is. And if that qualifies, then they could tell you, we pay, $200 a day. And you would get reimbursed for that money. And then you would usually use that to pay your bill to the assisted living. It does not
Yes.
qualify for home care, but not with a skilled agency. That would be an agency that just does aid services, not with nursing, not with physical therapy. Yep.
There are different terms. There's so many different options. It's a quick read if you know what you're looking for. Mhm.
Yeah.
Mhm.
Yeah.
Yeah. Right. Yeah. Yeah, it's a strategy on making sure just get that clock ticking, and there are a number of ways to do it.
Yep.
Yeah. Oh,
It
yeah.
depends on the assisted living that you go to. They have what they refer to, let's say, as packages. So depending on which one you go to, because they're all different, right? They're all separate companies. Some of them have care that the aid would provide is included in your rent. Other companies don't. So your rent is separate. And then if you need help from an aid, then you're purchasing that piece separately. Or maybe you need a nurse to help you with your medicines in the assisted living. Some of those things are included in your rent, and other companies, they're not. It's like a la carte. Is that the right way to say it? Yeah. So it depends on where you're going. And this gentleman right here is a wealth of knowledge about all that stuff.
Yeah, there are bespoke levels of what you need. And it can start as something as simple as I have compression socks and they're really hard to put on, or I get dizzy when I go to tie my shoes. Well, that's dressing assist. And so you need that. But if I need two people to help me get out of bed, that means I need two people to get me on and off the toilet, in and out of a chair. And so you need much more attention, and they'll have those on gradated scales. So the person who only needs help with the socks is paying much less than the person who needs two people helping them. It's an effort to be transparent, but what happens is it's complicated because, as MJ said, we work with 130 assisted living communities in Westchester and Fairfield County. they're all different. How they do, and they're doing the same thing, right? Because they're all hiring aides and a nurse to supervise aides to deliver this care. It's just how are they going to assign the costs for their business? And they're all different. Anything else? Then I'd like to thank MJ and
You're welcome.
Thank you.
My pleasure.
And thank you for all attending. If you missed something, I know you touched on an issue earlier about insurance and things like that. Go to the previous episodes of this. We had one, local resources, that touched deeply on that. You can find that links on the library website, on our YouTube channel. These have all been recorded, so you can get that. And the purpose of this has all been about getting these professionals out in front of you guys, so you know who's out there to buttonhole with your particular questions. Okay, there's a social worker at a skilled nursing facility. There's a nurse at the home health. Who am I talking to? Who am I going to get the authoritative piece? Because if you're just going to zoom around the internet, you're getting pitches, you're getting marketing. It's not bad, but you're not doing the research you should be doing. Susan always says your mom deserves better than a Google search. And I think that's what it sort of comes down to. We've gotten very lazy about, I can just get it from this, even with AI. But talking to an expert, and how many things did MJ and Ashley sort of struggle with articulating because it's complicated, and they deal with it all the time. So how can you expect to get it really quickly? Anyway, thank you both very much.
Well,
thank you for
Thank
attending.
you. Welcome.